Welcome to the Autism Navigating the Journey. I am very proud. My name is Kathleen Stengel, and I'm happy to lead the team at Neurabilities, where we provide services for neurologically fragile children from birth through, their lifetime. And I am happy to introduce the panel this evening on navigating the autism journey. We have a series of speakers this evening that go across medical diagnostics, through neuropsychological diagnostics, and then through treatment. And I'm happy to introduce Dr. Lisa Alberts here. She is a psychiatric nurse practitioner. She'll be leading us off today, and she works for us at Neurabilities Healthcare. Dr. Alberts holds a doctorate of nursing practice from LaSalle University in Philadelphia, and she's also board certified through the American Nurses Credentialing Center. She's an adult health nurse practitioner as well as a psychiatric nurse health practitioner, and we thank her for not only her service for the past 30 years, but to be able to explain it to those of us who've been in the field for some time in a very comprehensive way that allows us to understand kind of the dynamics of the disability. When asked about, why she got in the field or how she started her career, she was introduced when she was 17 years old, when she worked at as a camp counselor, for an organization who was serving individuals with developmental disabilities. She remembers those experiences fondly, and that was kind of the foundation of her career path, and we're very thankful to have her here this evening. We also have Dr. Aslan Theobald. She is a licensed clinical psychologist and formerly trained as a neuropsychologist and also with Neurabilities. Dr. Theobald completed her master's degree and her doctoral degree in clinical psychology from LaSalle, there might be a little theme here, in Philadelphia, with a concentration on child and family psychology. She specializes not only in neuropsychological assessment, but kind of the assessment of the entire family dynamic, as well as the neurological needs for individuals with ADHD, with autism spectrum disorder, Tourette syndrome, traumatic brain injury, learning disorders, and dementia. Very happy to have you here, Dr. Theobald. She also personally has 3 children, and she shares that parenting is one of the most difficult jobs that's full of rewards and challenges. She pursued the field of neuropsychology to help families, parents understand their child's strengths and their weaknesses so that she could help them guide these children towards their path. So for a neuropsychologist with that amount of training to say, hey, guess what? Parenting is the hardest job. Dr. Theobald has a lot of empathy for a lot of our families, and we're happy to have her here this evening. And Erin O'Brien is a board certified behavior analyst, and with only having 55,000 in the country, we're very happy to have her here. Thank you, Erin, for joining us. She leads our ABA therapy team as a clinical director in Neurabilities in Cherry Hill. She started in the field as an undergraduate at St. Joe's and continued her entire graduate career with a master's in learning disabilities from Rowan University in New Jersey. So back and forth across the river. Erin received her master's certificate in behavior analysis from St. Joe's, where she started her experience. And this is early on in her career, she worked with medically fragile children who were neurologically fragile, and this sparked her desire to continue working in the field for neurodevelopmental needs. She also really enjoys positive reinforcement, as any behavior analyst does, and one of her favorite parts of her job is when the light bulb finally goes off that, oh wait, if I do that again, it'll happen over and over. And Erin loves when they get that click and can push it forward. Thank you to all of our professionals for joining this evening. I'm going to pass it over to Dr. Alberts.
Good evening, everybody, and welcome. Autism is a neurologically based disorder, and it affects children and adults and impacts them throughout their lifespan. Ideally, we like to think about diagnosing autism early and improving those outcomes later on in life. The Center for Disease Control and Prevention reports that 1 in 44 8-year-olds in the United States is diagnosed with an autism spectrum disorder. And that rate continues to rise over the years. That data is managed by the Autism and Developmental Disabilities Monitoring Network through the CDC. And 47% of 8-year-olds that were evaluated at the 36-month mark. And that's also an increasing rate. Now, tonight, while we navigate the journey and begin our journey this evening, we're going to provide some strategies for you. And I'm going to start off with talking about the differences between monitoring, screening, and diagnosis of autism spectrum disorders, and the impact and importance of ongoing treatment in your journey. Next slide. Oh, thank you. Nope, back one. So monitoring is something that parents do, and it's the beginning of your journey. Monitoring your child should reach certain developmental milestones in how he or she plays, learns, speaks, acts, and moves over the course of their development. And watching these milestones and monitoring them is a way to track their development and act early in the event that you have a concern they're not gaining those milestones as they should be. Screening, on the other hand, is something that the primary care practice typically does, or the family practice. They follow certain guidelines established by the American Academy of Pediatrics and the Center for Disease Control. And these guidelines tell them that they need to screen every child at a well visit at certain ages for autism spectrum disorders. So if this is not happening in your journey, it'd be a good thing to ask that pediatrician or that family practice physician or provider about screening for autism spectrum disorders. And we'll get into that in a little more detail. And then there's diagnosis. The formal diagnosis is typically done through referral to a specialist. And we'll also describe that in a little more detail. So monitoring those milestones. Milestones matter. There is a program that was developed by the Center for Disease Control and Prevention, and it's called Learn the Signs, Act Early. If you're not aware of this program, it would be great for you to go into this link and the website from the CDC, and they have free downloadable toolkits and milestone checklists, and actually an app you can put on your phone, which is free to parents. And it helps you understand and learn what those milestones are from 2 months of age through 5 years of age. It's specifically designed for parents. And there are also screens for adults, but those aren't yet validated. So if you have an opportunity, go to this site and download the information on Learn the Signs, Act Early. Monitoring is a huge first step in managing your journey. And that's something that parents can and should do for their children. If there is an issue that arises when you're tracking milestones and you believe that your child is not gaining those skills that they need to an appropriate age, early intervention is the next step. And early intervention, both in New Jersey and Pennsylvania, New Jersey statewide under the age of 3 and Pennsylvania under the age of 5, there's no need for a referral. So if you're monitoring using the Learn the Signs, Act Early app on your phone, or you go through the website and you notice that your child is not crawling, walking, talking at an appropriate age, then you can call these numbers and seek consultation with the Early Intervention Network. There's no need to wait. In fact, the advice is the watch and wait is not the best approach to use in terms of monitoring and milestone acquisition. So screening is the next step. And that happens at the primary care practice, the family practice. And it's a routine part, again, of your child's well visit. The MCHAT, or the Modified Checklist for Autism in Toddlers, is free. It's a free screening tool for clinicians. It is validated from children 16 months to 30 months. And the American Academy of Pediatrics suggests to every family practice and pediatrician that they use the MCHAT at 18-month well check and 24-month well check. So this is an example of a screening tool. There are lots of other examples here that cover screening individuals across the lifespan. There's the CARS, which I don't have listed here. There's an under 6 version and an over 6 version to adult, which is an autism rating scale. There's the Survey of Well-Being for Young Children, which is a parent observation scale. There's the screening tool for autism toddlers and young children. There's the Rapid Interactive Test in Adolescents. And there's Community and Symbol Behavioral Scale for infants and toddlers, and the Social Communication Questionnaire for older children. All of these screens and examples of how to screen are on this website through the American Academy of Pediatrics and the toolkit. And then we come to diagnosing. Making a formal diagnosis should be a comprehensive process. Typically, after screening, the family practice will refer you to a specialist of some sort. That could be a developmental pediatrician, pediatric neurology, or psychology to make that formal diagnosis. Many times, the part of the assessment for the comprehensive diagnosis is completed in early intervention. To do a comprehensive diagnosis, there has to be several parts. One is an interview, which is a clinical interview, typically using the Diagnostic and Statistical Manual criteria for autism. And then there's a developmental evaluation, which is often completed in the early intervention network. And you have to understand also adaptive skills and intellectual functioning. So a comprehensive assessment is typically done with someone who has specialized training. The ADOS, or the Autism Diagnostic Observation Schedule, and the ADIR, Autism Diagnostic Interview, are completed by these specialized trained people. The ADOS is available and validated for children 12 months and older into adulthood. And it is by and large highly recognized as a gold standard measure for diagnosing autism at any age. It's an observational assessment. Ongoing treatment is really important, and that's where the journey continues. Treatment needs to be multimodal, and what I mean by that is there's lots of different team members involved in your care, the care of your child or loved one over the course of a lifespan. That may be the primary care provider, medical specialists, therapists, occupational therapy, physical therapy, speech therapy, art, music therapy, social skills, behavioral analysis, educational components. And all of these folks are team members that help you along the path. This is a lifelong journey, and there are conditions and experiences that children and adults have over the course of their lifetime that may impact their success and how they journey through autism. There are certain conditions that co-occur in the autism spectrum disorder realm, and those are ADHD, anxiety, depression, epilepsy. So it's important that you have the right team members to help you transition and make that journey through the lifespan. So now I'm going to turn over to Dr. Theobald, and she's going to talk a little bit more about prevalence in autism spectrum disorders and sex differences. Dr. Theobald?
Thank you, Dr. Alberts. Hi, everyone. My name is Dr. Oslin Theobald, and I'm a neuropsychologist at Neuroabilities, and I specialize in working with children as young as 12 months to assess and diagnose and determine if autism is something that is prevalent in their presentation. The diagnostic criteria for autism really doesn't discriminate between boys and girls or between men and women, but recent research does suggest that autism spectrum disorder may look quite different in girls, and so different, in fact, that it can sometimes be difficult to diagnose. We have adult women and men coming in for consideration of autism spectrum disorder diagnosis, something that they may have been struggling with for many years and just were never able to quite pinpoint, and perhaps doctors that they had been seeing in the past just weren't able to quite figure out. And often women are the ones who tend to have been struggling with these various different symptoms they just weren't able to quite figure out, and have now that we are learning more and more about these differences between sexes and how autism can manifest and can present in boys and girls, men and women, we're learning so much more, and we're able to fine tune and hone our diagnostic criteria and really look through a lens of how individuals, men, women, boys, girls, present with different symptoms. We're able to look at different symptoms of anxiety, perhaps obsessive compulsive disorder, social anxiety, and how all of those pieces can be pulled apart, often through a very in-depth interview, observation. If it's an adult, what we're looking at, maybe even speaking to their parents to get a sense of what this individual's behaviors were like as a child, so that really we can really do the best job to serve our patients so that we can help them by providing an accurate diagnosis for something that they may have been struggling with for many years or decades. So I'm going to focus more on young children and what those differences might be between the sexes, between boys and girls. So in the past, oops, can I just go back one slide? Thank you. So in the past, the statistic was that boys were 4 times more likely than girls to be diagnosed with autism. But some more recent analysis, and that's some of the research that I was talking about that's a bit more recent in nature, really does suggest that that ratio of boys to girls is closer to 3 to 1. Boys still being diagnosed more than girls, but you know, we are kind of learning more and more about these differences in the autism presentation across the sexes. And the studies have shown that girls are likely being overlooked, given that our current diagnostic tools that Dr. Alberts referred to, while they're very, very good and very well regarded, but those do show some differences in the presentation of autistic symptoms between boys and girls. So some of the most common symptoms that are associated with autism, I'm going to go through some of these quickly, but we just need to remember, and this is what we as clinicians have to remember with each person that comes in as a new patient, is that each person is an individual. Each child is very unique in how they present their history, their family history, their medical history, and we do have to take all of that into account when we're considering an autism diagnosis. So some of the most common symptoms, and again, not every individual is going to have these symptoms, but some that are the most common are communication deficits. Typically the first difference that parents will notice, and they might bring it up at a pediatrician well visit, is that my child isn't talking yet, or my child's still only saying single words and they're 18 months old, or my child only really has this 5 to 10 word vocabulary and they're not increasing from there, or my child had more words, but they have lost some of those words in their vocabulary, and there are instances of using expressive language and speech are decreasing, or what we call as regression of skills. Some children may echo speech. The term is echolalia. You may hear children echoing what they heard, echoing their parents, echoing their peers, repeating what they hear on a television show, repeating dialogue, repeating songs, or even repeating things under their breath, kind of very quietly, maybe repeating just the end of what mom or dad may have just said to them. A difficulty with reciprocal social interaction. So what that refers to is just sometimes a lack of interest in others. Teachers or daycare workers may say to parents, I noticed that he or she tends to just like to play alone. They tend to like to do their own thing. They don't really like to be involved with other peers or involved in circle time. Having some more limited play skills, meaning some very intense interests in few things or few activities, as opposed to taking up a wide variety of activities in play. So this may be a child who has a really intense interest in airplanes or in transportation or in a certain show, and they watch that show over and over and over again. They may have difficulty understanding others' feelings or perspectives. So if they heard a loud boom in the house, or maybe they even heard somebody yell ouch from another room, they may not come and take a look, or they may come take a look, but not necessarily demonstrate empathy or concern or ask the other person, are you okay? There's some cognitive differences in problem solving. We talked about perspective taking, some more rigid thinking, kind of. Some people might refer to that as just black and white thinking, having some difficulties understanding sarcasm, a more literal sense of using language, having a hard time understanding humor and jokes. You may see your child has some problems with transitions. So if it's cleanup time, or if there was going to be a trip to the mall or to get ice cream, and then suddenly that got changed or delayed by 15 or 30 minutes, that child may have a lot of difficulty understanding that change and may even wind up having a tantrum or a meltdown. We also see a higher incidence of meltdowns, tantrums that can be prolonged and fairly excessive among individuals who have autism. There's also sensory differences. So you may notice your child smelling things before they eat them, or rubbing things, rubbing a parent's skin, or rubbing a blanket or a pillow, having an intense interest in looking at lights, maybe looking out of the corner of their eye, or having a really heightened sense of smell, even gagging when they're smelling certain things, and have some aversions to certain types of textures of food, aversions to clothing tags, and things of that nature. So why are more boys diagnosed with autism than girls? Well, autism may develop in different regions of the brain in girls than it does in boys. And that can lead to different presentations of the strengths and the difficulties of autism. So girls with autism have a larger number of genetic mutations than boys, and that suggests that they require a larger kind of genetic hit or a genetic load to develop the disorder. So females may have a bit more of a protective factor than males, and the neurological profile among girls may highlight what drives something called the female protective effect, in essence making girls a little less susceptible to developing autism than boys. And the male or female ratio differences may actually result from this underestimated number of females with autism due to their kind of non-male typical presentation. What I mean by that is much of the diagnostic criteria over the decades that it has been analyzed and researched and written in diagnostic manuals has been written through a predominantly male lens, with much of the research including boys as opposed to girls in the studies. And the reason for that is because there are just more boys that have been diagnosed. So just by nature of this larger male-female ratio, there's going to be more boys in some of these studies. But some of the more recent research is really trying to make strong efforts to include girls in the research and trying to match those numbers a bit more appropriately. So that can also lead to some underdiagnosed girls. So how do the sexes differ across the autism spectrum? I kind of categorize these by boys and girls, but again, just wanting to reiterate that each child is unique and an individual. So this doesn't mean that if your child is, if you have a girl, that if she is demonstrating some of the symptoms I'm talking about in boys, many girls have all these symptoms, and there's quite a bit of overlap. But much of the research has picked up on some of these pretty distinct differences in how boys present with autism and girls. And from our perspective as clinicians, we need to pay attention to these. So when we're asking parents and caregivers these interview questions, when they come in looking for a diagnosis or looking to see if autism is part of their child's symptom presentation, that we're able to ask not just a question, but maybe drill down and dig a little deeper to make sure that we're capturing what we're finding in the research so that we're making accurate diagnoses. So boys might be more likely to stim. That's a term that's often used to describe things like spinning in a circle or rocking back and forth, kind of displaying these repetitive motor movements that we associate with autism. Whereas girls may have fewer of these stim-like behaviors, or they may be less noticeable. I recently had a parent say that their daughter, I think she was 6 or 7 now when I saw her, but when she was 2, she engaged in a hand flapping motion, but she's become much more aware of it. So now that she's in elementary school, she tends to keep her hands kind of tucked under her legs so that her hands won't flap, and she just kind of gently moves her hands so that she's able to kind of manage some of the social stigma so that she doesn't experience that negative impact of that stimming behavior. Girls may also manifest some of this stim behavior as like reenacting scenes from movies or listening to the same songs as their repetitive behavior, whereas boys are more likely to display their repetitive behaviors in motor movements. Boys also have some more intense interests that are seen as less similar to non-autistic children. So that might be things like memorizing facts, memorizing president and vice president combinations, being really interested in maps or the weather or math, whereas girls do have intense interests. They're prominent, and we can pick up on those when we're interviewing parents or caregivers, but they're a little bit more similar to non-autistic children than boys. So a girl may have a really intense interest in dolls or certain Disney characters, horses, or really intense interest in arts and crafts. But when you dig a little bit deeper, you notice that it's a very intense interest in nature, but because it's sometimes a bit more typical, parents or teachers often can dismiss it as that doesn't seem unusual. Boys tend to have some limited pretend play. Maybe you might see more lining up of toys or lining up of toys and classifying them by size or shape or color. Whereas girls may appear to engage in pretend play, and parents will often say, sure, my child engages in pretend play or imaginative play. But when you dig a little deeper, that pretend play may often be something like reenacting their classroom or arranging stuffed animals according to what their classroom looks like, or rearranging things according to the school lunchroom. So it's not necessarily creative or interactive in nature. Boys also, we see that intellectual skills or IQ doesn't play as big a role in regarding increased or decreased presentation of autistic traits, whereas in girls, typically girls with a higher IQ tend to be able to minimize or something called mask their autistic characteristics, like the example I gave before about the young girl who was able to now put her hands under her legs so that she didn't have obvious repetitive stim behaviors noticeable to her peers. A couple more differences. So boys might be less likely to respond when their name is called. Typically we'll ask if you walked into a room and you just started talking to your child, or if you called their name, would your child be likely to respond, or would they kind of more stay doing whatever it was that they were doing and not respond? So boys are a little bit less likely to respond when their name is called or when someone tries to start a conversation, whereas girls may be more likely to respond to nonverbal cues, like someone pointing or shifting their eye gaze to direct their child's attention to something maybe across the room. Boys can be a bit more aggressive or externalize their behaviors, meaning that some of the boys' behaviors might be more visible to others, whereas girls are a bit more sensitive to things like sensory input, and that can cause some overwhelm. So being overwhelmed by crowds or by lights or by being touched, girls may tend to get overwhelmed by that and engage in either withdrawal behavior or even have a meltdown or a tantrum because of that sensory overload, whereas boys might be more overt in kind of externalizing and being a bit more hyperactive and a bit more aggressive in nature when they tend to become overwhelmed. For boys, social communication issues have become challenging pretty early on in the early childhood period, whereas girls may appear a bit more socially engaged with their peers. Parents may say, report that their daughter has lots of friends, and the teacher is saying that they're noticing that child is engaging with other children on the playground, what appears to be just fine. But as girls tend to get more into that middle school age range, 5th, 6th, 7th grade, that is when they tend to experience more of the neglect and the rejection by their peers by middle school. Whereas for boys, it tends to occur a bit more early on in the elementary school years. Girls are more likely to display anxiety and depression, whereas boys are less susceptible to anxiety and depression. And for boys, you may notice that boys are more likely to be loners or just limit their social interactions, especially in the teen years, where they're less likely to share information about their day or their experiences, less likely to share any emotional feelings. Whereas girls, they may, in their teen years, continue to appear immature in nature, where you might notice a teenage girl still wanting to take a stuffed animal to school, take a comfort item like a blanket. They may hide it in their backpack, but they're more likely to come off as socially immature to their peers. By the teen years, girls may still be more likely to play or prefer to play with younger children. Girls can be excessively chatty, so that may come off as being more socially interactive. But when we dig a little deeper, it's really more one-sided in nature. It might be a girl telling, everything she knows about, a certain interest or something that she's very, very into, but it's not necessarily reciprocal in nature. May come off as getting talked at than having a conversation with someone. Girls can also tend to have, more so than boys, a really strong sense of justice. Girls may be more likely to shush their classmates or repeat rules to their classmates, reminding others to follow the rules, correcting others, which can often lead to bullying and other social difficulties. One thing that's really common, and I want to highlight among the sexies, is that both boys and girls really have a much higher likelihood of getting bullied compared to their non-autistic peers. Kids that are autistic are at a 10 times higher rate of getting bullied by their peers as opposed to non-autistic children. So that is one thing that is really prevalent, and something that there's a lot of research going into. And I know schools have really taken the reins at doing some of the bullying programs among all students, but there's certainly a lot more work that can be done in that realm. So autism has the diagnostic criteria. We typically follow the DSM diagnostic manual. Those diagnostic criteria have really been through a historically male lens. The earliest research among individuals with autism were exclusively with boys. So we are using the tools that we have to diagnose and screen for autism, while taking into account the fact that those have been primarily based on data from boys and often don't necessarily account for the full variation in autistic characteristics across the sexes. So that is something we as an organization are taking into account every day with the folks that we see. But as a result, unfortunately, across the autistic community, many autistic women and girls are diagnosed with the condition later in life, or not at all. And this underdiagnosis really may have led to that skewed sex ratio that we talked about earlier. Young girls who do get diagnosed early on, meaning by their 3rd birthday, tend to display more symptoms. Their symptoms of autism tend to be consistent more with a boy's presentation than what I've talked about with some of those differences are between girls and boys. So the girls that are getting diagnosed very early on may certainly be more likely to have speech delay, more likely to engage in some of those repetitive motor movements, might be more likely to be somewhat socially withdrawn, difficulties making eye contact. You may not see the child engage in something called a reciprocal social smile. So even at 8 months, parents are smiling at their child and the child's not smiling back. So girls that are diagnosed very young tend to have a presentation that is more male-like. And often those early diagnoses among girls tend to be a bit more severe in nature than girls who are diagnosed maybe, around ages 8 and up. Their differences are a bit more subtle. So there's a lot of benefit of improving our understanding of autism across the sexes. One, it really helps to develop some non-biased diagnostic criteria and some more tools that account for these differences across the sexes. Helps to raise awareness among health professionals who are really involved in this early identification and early diagnosis of autism. As we know, early diagnosis leads to early intervention, and that's something that's really important among individuals with autism. Understanding how autism presents differently in females can also help us in understanding their different needs, providing them with the right supports and interventions. Like I said before, repeat it many times, every person that we see is an individual. So the recommendations we make in our reports after we provide the diagnosis, after we do a neurodevelopmental evaluation, are very individualized. They're really taking into account the family's needs, what the family has access to, what the child's most impairing symptoms are, as opposed to kind of blanket recommendations that could apply to just anyone. Certainly we do best practices, but really trying to take that individual into account as much as possible. And the different ways that people experience the world will vastly affect their behavior, including autistic behaviors. So diagnostic criteria for one group or culture really can't and shouldn't be representative of the autistic community as a whole. And with that, I am going to turn it over to Dr. Erin O'Brien to talk about ABA, or Applied Behavior Analysis.
Okay, thank you, Dr. Theobald. So today I'm going to talk a little about ABA, which is one of the treatments for autism. I'm going to talk about what it is and how it can help a child throughout the different stages of life. So first, what is ABA? So ABA stands for Applied Behavior Analysis, and it uses methods taken from scientifically established principles of behavior. So those methods are applied to increase behaviors that are helpful to the individual and to decrease behaviors that are harmful and or affect learning. So it's important to note that whenever we're looking to decrease a behavior that may be harmful, such as a tantrum or self-injury or aggression, we're always teaching a new skill to help get the individual's needs met, in addition to other skills. ABA is widely accepted as an effective treatment that is supported by long-term research, demonstrating success for individuals diagnosed with autism spectrum disorder. So while today's talk is focusing on autism, I think it's important to note that ABA can be an effective treatment for a variety of disorders, including things such as ADHD. It can help individuals with traumatic brain injury, eating disorders, substance abuse issues, and even adults with dementia. But overall, ABA is an evidence-based intervention. It's supported by decades of research that demonstrates its effectiveness with learners both with and without special needs. So the treatment plan, the goals, and the programming are developed and overseen by a Board Certified Behavior Analyst, or BCBA. So in order to be certified, this person has to complete a master's degree in ABA or related field. They must complete extensive supervised field work and also pass a national certification exam, in addition to completing ongoing continuing education. In addition, some states do require a license to practice ABA. In Pennsylvania, a license is required, and New Jersey is working towards licensure at the moment. The majority of treatment hours are provided by an ABA therapist. So this person can go by different names. You may hear them called a BHT or a behavior tech. There are also some that are certified as an RBT, which is a registered behavior technician. And those people are certified by the same board that certifies BCBAs to be a direct staff. So the BCBA will train this person, and they provide ongoing supervision to implement the treatment plan and the goals. The number of treatment hours, can you go back, Sandra? Sorry. The number of treatment hours recommended and the location where those services happen, so that may be in the home, they may be center-based, they may be in the community. All of that is determined by the initial assessment as well as ongoing assessment. So as needs change and skills develop, the treatment plan is adjusted to meet the learner's needs. And finally, each plan is written based on the learner's individual needs. So Dr. Theobald touched on this, and you'll hear me talk about it a lot. Everything is individualized. So I may have two learners that need to learn the same skill, but I'm going to use different strategies with one learner compared to the other based on what works best for each of them. Okay, so ABA programs can be intensive. So this means that there is a low instructor to learner ratio. So typically when we start out, we're doing one-to-one instruction. However, there are some goals and some formats that can be done in a group, but mainly it's one-to-one. And this also means that it's a high number of hours. And we do this to maximize the number of learning opportunities that are available. Here's that word individualized again. So as I've already touched on, ABA programs should be individualized to the learner, always taking into account their strengths and weaknesses, their interests, their preferences, and their needs. They're also comprehensive. So this means they can incorporate several different instructional strategies. So we can use things such as shaping, discrete trial teaching, natural environment teaching, task analysis. All of these are used to ensure that a variety of skills are taught, but also generalized across environments. So we have to make sure that our learners can take the skill and use it outside of the treatment setting. Otherwise, the new setting won't really be affecting meaningful change in the learner's life. Training is provided to the ABA therapist, as I mentioned, but in addition, there are other individuals in the learner's life that can be trained, such as parents, siblings, or teachers. Data is collected and analyzed continuously. We do that to know if what we're doing is working. And if it's not, if we're not seeing progress, we can adjust our treatment and our strategies that we're using. And finally, social validity is very important. So we want to make sure that we're choosing goals and improving behaviors that are socially significant to the learner and their family. We want to make sure we're choosing things and working on things that are going to enhance and improve their life. So the first step in accessing ABA services is an initial behavior assessment, or an IBA. So in this process, there'll be a parent interview that's conducted. The BCBA will talk to the parent, ask them about their behaviors of concern, the child's strengths and weaknesses, and what their goals and desired outcomes are from treatment. What do they want to see to gain? What do they want to gain from this? The next part would be an in-person observation and assessment. But at this point, we'll look at some skills. We'll see what areas really need to be worked on, give us a better picture of strengths and areas of need. Parents will also be asked to complete some questionnaires and rating scales. So we'll take all this information, and it allows us to develop our treatment plan. And this is where we're going to determine the behaviors of concern, what the function of those behaviors are, or what need is being met by engaging in those behaviors. And then we're going to talk about, in the treatment plan, the new behaviors we're going to teach in order to get those same needs met in a more safe and efficient way, in addition to building other skills. So if your learner is beginning ABA as a younger child, so we're talking about under 5 years old, the recommendation is typically early intensive behavior intervention, or EIBI. This typically involves a high number of hours, so something between 25 to 40 hours a week, depending on the needs of the child. And these hours are recommended at a higher intensity because we want to build strong foundational and prerequisite skills that we continue to build upon as the child moves forward into settings that provide lower levels of support. So when we have that strong one-to-one instruction, as a child maybe moves on to school, they're not going to get that same level of support. So we really want to work on building all of those prerequisite skills. So when we're doing early intensive behavior intervention, there's a big focus on communication. And the skills we focus on under this are teaching children to request, having them follow directions, receptive and expressive skills. And we'll do this using the mode of communication that's suited to the learner. So some children will use vocal language. Others may use sign language, pictures, or an AAC device. So we'll always cater it towards that mode of communication that suits the learner. We also work on building cognitive skills, things such as matching, sorting, and patterns. These are all building blocks that we can build upon to teach bigger skills moving forward. Play skills are a big one. All of our kids learn best through play. So it's really important at this age because it also forms the basis of leisure skills. So we focus on functional play as well as encouraging creativity and pretend play. Social skills we focus on include things like cooperative play with peers. We work on turn taking, responding and initiating peer interactions, and greetings. And finally, adaptive skills. So this is things like toilet training, hand washing, self-dressing, and toothbrushing. A lot of kids have a hard time tolerating these things. So maybe we just work on tolerating those activities. Some kids are ready to learn to complete them independently. So again, it's always individualized, but these are things that we can focus on during this age. So as children get older, they move on to elementary and the adolescent years. We kind of shift our focus on the skills that we're working on. So at this point in the learner's life, we want to build skills and a foundation that's going to promote independence, but also lay the groundwork for a fulfilling adulthood. So as far as social skills, some examples of things we can focus on are making and maintaining friendships, safe social media use, conversation skills, making sure you can learn to do that back and forth. When we're looking at adaptive skills, we can focus on independent completion of hygiene routines, beginning to learn to prepare simple meals, and then completing chores such as making a bed, folding and putting away clothes, anything that may be meaningful to the learner, their family, and their routines. Another important area to focus on at this age is expanding leisure skills. So we all know our kids love their iPads, but sometimes iPads break, sometimes the power goes out, you don't have a charger. So it's really important that they have other things that they can do, skills that they can use during leisure time to enjoy that time. As far as executive functioning skills, we can teach kids to self-monitor their own behavior, teach them and reinforce flexibility, as well as identifying and managing their emotions. And then finally, we can look at prerequisites, pre-vocational skills. So things such as following a schedule, sorting items, money skills, all of these, again, are individualized to the learner, but we really want to always focus on teaching and building new skills throughout a learner's life and promoting that independence. And finally, just some other considerations. It's very helpful to have collaboration across the team that's working with the child. So as I mentioned before, we're always collecting data on behaviors of concern, as well as data on progress in gaining new skills. So our data can be used in collaboration with medical professionals, related services personnel, such as occupational therapists and speech therapists, and even the educators. So an example of this is if a child's doctor makes a medication change, the data representations from the ABA program can be shared with the doctor. And it can help them make further treatment plan changes based on how the medication has impacted the learner's behavior, and we can help provide that information. Another important part of ABA programs is parent training, or what one of my colleagues prefers to call caregiver collaboration, which is a term I prefer as well. So this is built into many ABA programs as a way to transfer skills to caregivers, which is also an important step when we're working on generalizing and maintaining those skills outside of the therapy setting. We also generally conduct reassessments every 6 months, as well as continuous review of progress and data. So we evaluate the progress, we look at any continued concerns, and we also look at if the current level of service is appropriate, or if maybe we need to increase it or decrease it. So the goals and the treatment strategies are continuously monitored, and we update them as new challenges arise or as goals are met. So essentially, we're always focused on working ourselves out of a job and transferring those skills to the learner and their caregivers. However, there may be situations where maybe all the treatment goals have been met and we're recommending discharge. And then as time passes, the learner has new challenges that arrive, different stages in their life. And at that point, we can always reassess, write a new treatment plan, and access treatment again. So ABA is always there at every stage as they move along. So the important takeaway is that ABA is a treatment that can be accessed throughout the years as a learner develops in collaboration with the entire treatment team. It can also assist in informing treatment decisions as children and families navigate their autism journey. So I believe the next few slides are some references and resources. And right now I can pass it back to Kathleen for any questions.
Thank you, Erin. Thank you to everybody who participated. We do actually have some questions, but I just want to point out the very clearly obvious that we do this navigating the journey discussion almost every 6 months because this never gets any easier. The idea of from diagnostics all the way through treatment and the ongoing evaluation, coming back and continuing to look and continuing to assess, it's burdensome on the families, and it's definitely burdensome on, all of us together if we don't understand it. That we find that this is so important to do this very slow, diligent understanding of step 1, step 2, step 3, in hopes that you guys will pass it along for families who can hear it again and again and again, because it never gets any easier. No matter what developmental milestone our children hit, there is yet another analysis of how can we get it better? How can we move it forward? That is for our typically developing kids as well as our kids on the spectrum. So I just want to make that very clear that this is part of life, that we go through this entire journey. So thank you everybody for some of the questions that we had. I'm going to actually go in order of from medical to neuropsych over to behavior, just to keep it in line. Dr. Alberts, do you recommend very early on getting a full medical biological analysis, including EEG as well as genetics? Is it necessary for everyone as soon as we start to have concerns? What are your thoughts there?
So, the short answer is yes, because we understand that, incidences of epilepsy in children and adults on the spectrum are at least 30% higher than not on the spectrum. So it's important to rule out what we can rule out so we can hone in on what it is we need to treat if we're treating a behavior with a medication in particular. So before applying any psychopharmacology, I always suggest that we do a thorough neurological, medical workup to assess for underlying medical conditions that can also cause behavioral challenges. If you have limited language or difficulties with communication skills, you use your behavior to communicate to others. So it's really important that we not miss out on that, that we make sure that we do a thorough and neurobiological assessment, making the diagnosis, but also applying treatment along the journey.
And you've said it once before about, coming back to analyze that. So on a regular basis, like generally speaking, going back to either my developmental pediatrician or my neurologist or my specialty care physician, would you recommend more than an annual for some of the children we have?
Yeah, absolutely. In fact, I'm always having that conversation with families. I had an adult just this evening email me and say, we have an acute increase in self-injurious behavior. What do we do? I said, well, the first thing we do, if they're targeting their ears, is make sure they don't have an ear infection. He's an adult, but he still can have ear infections. Make sure he doesn't have an ear infection. Make sure he's not constipated. Make sure he's not ill in any way. And then we can talk about what the next steps are. So you're always going back to that. And something that Erin said is really, really important, I'd just like to highlight, and that is the use of direct observation of behavior to give insight to the clinician, the prescriber. It can be very, very useful. As a prescriber, I ask for that data because it's important to see if I'm increasing a med or decreasing a med, what impact that has on someone's behavior. So it's really important to have that back and forth open conversation between all the team members.
Thank you very much. And I'm sorry, Dr. Theobald, I have a very loaded question for you. So in terms of when we hit puberty, what are the things that we have to pay attention for, regardless of gender, of sex, orientation? What do we have to pay attention to? And what kind of behavior should we look at that are typical versus not so typical?
That's a good question. So, for individuals who are autistic, having, I always try and recommend, certainly pre-puberty, there's so much overlap with other difficulties. We talked about intense bullying that can occur, even, just chronic, but maybe not necessarily physical bullying, but just chronic teasing that can be really debilitating and have very long-term effects on children and adolescents. So I often will recommend to parents, as young, starting at 9-10 years old, to begin identifying a therapist who is well-versed in, working with individuals on the spectrum, working with some of the, those adolescent pieces that can certainly change and evolve, working with kids who have, increased sex hormones and those changes that go on in puberty for boys and girls, and how to navigate that process. Often, certainly among kids in the autistic community who have lowered IQ or perhaps reduced language skills, they have difficulty kind of making sense of what some of these emotions are and what some of these feelings are. So having them paired nicely with a therapist who has known them for a while, that they feel comfortable with, that they are able to, speak with, is sometimes a little bit comforting for families and very helpful for the individual, so that they can begin talking about dating and hygiene changes and self-care changes. There's sometimes some kids sometimes lack in hygiene when they hit 12 and 13 and don't want to, and have to be made aware of some of these more self-care adaptive skills that can be targeted through ABA therapy, but certainly also with the help of a trained therapist. Also having a really open dialogue with your children early and often, letting them know, kind of, especially for kids who might be a bit more naive, what is, all of those kind of phrases of what kind of touch is okay, what kind of touch is not okay, and when to say something and when to let an adult know that they are feeling uncomfortable in whatever situation that is. Sometimes these discussions have to be, autistic or not, a bit more frequent and a bit more open and honest, and with very simple language that kids can understand.
I'll just add to that too, and mirror what Dr. Theobald just said. From a medical perspective, early education is good. So plan ahead of time. If your daughter is entering her menstrual cycle at 13 or 14, start at 12. And you can anticipate that there's some genetic component to that. So, what was good for you is probably good for her, but start early and plan ahead and have some strategies in place, so that you're not caught off guard and they are knowing what to expect.
It's beautiful. I have a funny anecdote I'll just share because I think it's appropriate, not because of anything else. Is we had an individual who I'd worked with for a long period of time, and they hit about 14 years old, and I still enjoy interacting as a friend and not so much as a therapist. But he said one time, they give me a coach. He used to call his paraprofessionals a coach. They give me a coach for, when I need to do schoolwork. They give me a coach when I need to learn how to swim. But nobody gave me a coach for this puberty thing. And so really, if you think about it, it's, we coach our individuals all through their journey, whether it's, neurotypical or not neurotypical. But that's that one black hole of we're not coaching anybody through. So I agree with you guys completely that start early and coach along, even if it's just education. So I won't give you a difficult question, Erin, but I will give you a hotbed one. It's not difficult, but it is definitely on the tips of many people's tongues, is that oftentimes we are siloed in the field of ABA, and it just so happens to be that our practice, luckily, focuses on that front to back, the holistic aspect of an individual. When we're talking about ABA and intervention throughout the lifetime, do you see a difference in terms of what goals you intervene with and who you have to work with? Dr. Theobald recommended sometimes a therapist. Do you see a difference across the lifetime with who you have to work as a BCBA?
I think so. I think at the younger ages, you definitely work more with like the speech therapists and the occupational therapists. But as kids get older, there are those different challenges, those social emotional type things that a lot of times are outside of our scope. So, we make sure we recommend to go to that professional that can help with that. But then we can always still be in collaboration and kind of back up what they're saying so that everyone's on the same page and supporting the child.
Yeah, I think that's phenomenal. And I love how you guys provide the data back to the medical professionals and kind of step back when you need to step back. And I think that prepubescent stage into adolescence is so important for cohesive treatment, kind of across the board. So those were the difficult questions that I had. I will open it up. We have about a minute left. If anybody would like to put something in the chat or ask the good clinicians on our line for any recommendations. I think some of this is review for some people, but I do think repetition is key for learning. And if we want to pass it on to some of our newer families, it's, You know, there's a long wait list these days, and any resources we can give is helpful. All right, so it looks like we have some people have a Zoom at 7 o'clock, and I don't see any further questions. Thank you to everybody who sent the very difficult questions directly to me. I appreciate being able to rephrase them for everybody. And I appreciate Dr. Alberts, Erin, Aslan, thank you so much. Thank you, Sandra, for getting this all together. Have a wonderful evening.
Thank you.